Right. Good morning, everybody, and welcome to this, our final instalment in the programme of support for elective recovery. This is our module on commissioning to optimise delivery. My name is Michael Watson. I'm a member of the Mental Health Intensive Support Team. I've been in the team since its inception 7 years ago. Before that, I worked in the intensive support team for physical health, for elective care, RCT 18 weeks and cancer. And before that, I did a number of operational roles in acute trusts. As ever, we'll be using the Menti system throughout the webinar, so please do point your camera phone at the thingy, QR code, and access Menti, or you can access it on your computer, menti.com, using the code 65370978 that you can see on the screen. Next slide, please. As ever, all of this information, including the slides and other resources, will be on our Futures site. The link, which is kind of scattered around the slide, which you'll get by email after the presentation. So today we're having a conversation about opportunities to optimise delivery in commissioning. So as my colleague Francis will cover in more detail, this is not a guide to commissioning. This is about how you, as a commissioner, can influence the delivery of mental health services, and some kind of key bits of information in terms of unintended consequences, how things can go wrong, how you can mitigate against these, and how you can do things to make sure things work as effectively as possible. So we are going to have a Q&A in the Q&A box as per usual, and unusually we're going to try to address some of your questions as we're going along, so please do put your questions in the box, and my colleagues Sean and Sarah will be patrolling, looking out, and we'll bring you in where we can do. As ever, we'll constantly be improving our resources on the Futures site, so please do make sure that you register with the Futures site and join in the conversation there. Next slide, please. So, who are we? I'm sure many of you know who we are, as this is the 7th of our webinars, but we do know from the feedback that a number of people always join for the first time, so please bear with. So we are the Mental Health Intensive Support Team. We're a small expert quality improvement team, part of the national NHS England support offer. We're a multidisciplinary team. We've got a range of people who are experts in healthcare management and clinical healthcare management. Those of us who, or those of the team who have a professional registration, are also experienced in acting as an expert clinical resource. And across the team, we've got backgrounds covering clinical, data, governance, operations, etc. And we're here to try to support systems to improve the mental health service delivery in terms of being safe, timely, efficient, effective, and patient-centred. Next slide, please. So this is the programme of support for mental health elective recovery, so elective as opposed to urgent and emergency delivery. So we developed this programme to try to support organisations moving out of the vicissitudes of COVID, and also to more broadly improve quality experience and outcomes for people in mental health services. We developed this based on our experience as a team of over 6 years of doing diagnostic reviews into a range of mental health services, including early intervention psychosis, children and young people's mental health, NHS talking therapies, and the assessments of the 4-week wait pilot sites for children and young people's mental health. We also borrowed the methodologies from our cousins in the physical health elective care programme and part of their post-COVID elective recovery programme. So we're trying to bring you best of breed, but plus our experience of working in the system. And we hope this helps you to improve your services and deliver more effectively for your patients. Next slide, please. So as I mentioned, this is our final module. So we've already covered the remaining modules on this page. But as you can see, they come under 3 kind of broad headings, which is setting clear standards and expectations, of which this is one of them, making sure you've got capacity and demand right through waiting list management and job planning, and proactively managing people through their pathways in terms of understanding what the pathways are, tracking people through them, and trying to improve flow. And it's our intention that by kind of following this methodology across the different modules, that they can help you to most effectively manage and deliver mental health elective services. So without further ado, I'll pass over to my colleague. I'll go on to feedback. I beg your pardon. Next slide, please. So as ever, we're really keen to hear your feedback, and there'll be information on how to feedback on this webinar at the end, as usual. But here's some of the highlights from what we got from last time. So broadly speaking, we got positive feedback on all of our webinars, which is really heartening. Most people are saying that their confidence and kind of capability had improved as a result of the webinars. We note that speaker handovers could be better and slicker, and we could take more time to introduce new speakers. So we've got a number of speakers coming up in the webinar, and we'll make sure that we do that as clearly as we can do. And finally, we had a suggestion about providing a kind of a brief key point handout with some links and reminders. It's a really interesting suggestion. Unfortunately, we didn't get it in time to action it for this webinar, but we are considering kind of wave 2 or phase 2 of webinars potentially for the autumn, and that's definitely something that we'll take on board when we come to those. So thanks as ever for your feedback. Please do keep it coming. Like I said, the link will be at the end. Now I will hand over to Francis for the Commissioning to Optimise Delivery webinar.
Thank you, Michael, and good morning to colleagues who have dialed in. My name is Francis Ibonke. I've also been working in the mental health intensive support team for the past 6 years or so. I have a number of backgrounds, primarily in performance and service improvement, in physical health, and latterly in the last 10 years in mental health. I want to very much welcome our colleagues who have agreed to share their work and experiences on this webinar. The aim of the webinar today is to share our learning as a team from our 6 years of supporting mental health systems around the country, so as to raise awareness, as Michael said, of some of the unintended consequences on mental health delivery that arise from the commissioning process. Next slide, please. So I just want to be clear what this webinar is not. It is not a step-by-step guide to commissioning mental health services, nor will it cover commissioning models or contract and payment designs, though this may be mentioned in passing. If colleagues want to hear more on these areas, let us know by feedback, and we'll flag it to our colleagues in the National Policy team, who we know have been leading sessions on the new commissioning arrangements. Next slide. So in this webinar, we want to begin a conversation with you, sharing some of our insights on the pitfalls and barriers, as I said, to mental health delivery associated with the commissioning process. We want to bring colleagues in the system to share the approaches they've taken to mitigate some of these. And since this is a conversation, we'd like you to get involved in answering each other's questions in the chat, the Q&A chat today. Share your challenges, share your positive experiences also. We very much hope that you will continue the conversation beyond this webinar, and therefore we've made a channel available for you to share your ideas with colleagues on mental health delivery. And we'll say later in this presentation where that channel is. Next slide. So we've distilled our learning and insights into a 4-part checklist of Chloe's key lines of inquiries to inform commissioners on the things to consider to optimise delivery. And the checklist is freely available on our Futures page when you register, and registration is free. Our team was commissioned to work with systems who were struggling in delivering the National Priority Programme areas of talking therapies, formerly known as IAPT, children and young people's mental health services, and early intervention psychosis. So this was prior to just prior to the ICS becoming formally established in statute, if you will. And although we mostly worked with struggling systems, we had the opportunity to observe good practice. So from our observations of systems who struggled, some struggled with a few areas or many of these areas on this slide here, starting with not understanding the unique nature of mental health need in their local population and the gap in capacity to meet this need. They also struggled with mobilising a multi-agency response, achieving an effective governance process, and also they struggled with leadership capacity to drive system partnership working. That really is essential in driving transformational work. We found that in many cases, there was not a shared view between providers and commissioners of the investment required to deliver. And furthermore, delivery was undermined by the absence of clearly defined service specifications. And often in these service specifications, outcomes were not clearly defined, and KPIs were generally limited to sort of the top level national KPIs. Systems also struggled with not knowing what good looks like in operational management processes within services. And finally, when seeking to take stock of what services were achieving, monitoring processes were insufficiently robust to understand the overall benefit of investment. So irrespective of your roles in the new or newish commissioning landscape, we believe that this webinar will still be relevant. Next slide, please. So just some start off generally with some general stats. Approximately 1 in 4 people in the UK, as you know, will experience a mental health problem each year. It is the second largest source of burden of disease in England at a total cost estimated of £105 billion per year. When people experience a period of mental illness, they want to recover as quickly as possible with the least intervention and stay well. No one will disagree with the ambition to have the most costly services to be the least frequently needed and instead have more services providing early support to prevent deterioration and people reaching crisis point. So what we want is a full range of services along the continuum of need to shift the dial of escalated need and risk. And when people need them, timely and effective interventions that move them towards their recovery goals, stepping up and stepping down according to their support needs in a dynamic way through each segment. There are times when specialist inpatient services are needed, but we want them for limited periods, ideally. That's the intention, at least. Next slide. But in reality, we are faced with significant demand variation and health inequity. Pre-COVID, we had long waits in services, but now waiting lists have grown further, arising from the rising need due to the impact of the pandemic. More than 1 million people are waiting for community services, mental health community services, and 1 in 4 mental health patients end up waiting more than 12 weeks to start treatment. According to a survey by the Royal College of Psychiatrists, 43% of adults reported that long waits have led them to experiencing worsening of mental health, and many are turning up to A&E or dialing 999 for help. The longer the wait for mental health treatment, the greater the impact in adverse health outcomes. This picture is predicted to worsen from the current cost of living crisis that is fueling poverty levels. The length of time people wait varies significantly depending on where you are in England. And we've got an example here at the bottom of this slide in the talking therapies services. There are often long lengths of wait in inpatient services, long lengths of stay in inpatient services. 1 in 10 inpatients are in hospital for over 3 months. Not only are inpatient services expensive, but lengthy stays make people lose life skills. And if we run out of capacity from long admissions, it means people who need beds are admitted out of area, away from patients' support network in regards to family and local health services. And as you're aware, Black people are overrepresented in specialist inpatient services, where they experience twice the rate of restraint than white people. People from Black and Asian backgrounds do not achieve equal access to treatment services in the community, and when they do access treatment, they are less likely to achieve recovery. Next slide, please.
Thanks, Francis. So we're coming on to the first of our Menti questions now. So as previously, please do use the QR code with the camera on your smartphone or other device, or go to menti.com, put the code in 6537. I'm getting some sorts of thumbs up there, which I guess is a positive thing. So I'll give you another sort of 5 seconds or so. Make sure you have plenty of time to get your smartphone out, do a little zoom. Right, next slide, please, Louise. So the first of our Menti questions today is, as a commissioner, and we are assuming that the majority of you here are commissioners, what are the main challenges you're facing delivering an effective mental health offer for your system? And this is going to be one of the word clouds. We love a word cloud. You've got a minute. Please populate our cloud. The region, ouch. Relationships, resources and funding, as you would expect. Funding and workforce, funding and workforce. So it doesn't come as a huge surprise to anyone, I think, that workforce and money are pretty much the biggest limitations. But I guess really what we're going to try and talk to you about today is accepting that there's nothing that we can do, either in a webinar or as a small national improvement team, to address funding or to directly address workforce. What are the things that we can do to make the most of the resources that you have got, whether that's around relationships, whether that's around referral numbers, whether that's around waiting times, ICB finance chaos, burn, and so on.
Indeed. Thank you very much, Michael. So there is, next slide, please, Louise. So there is too much to cover in this 90-minute webinar. And as I say, we have sort of a full checklist on our futures page. We want to prioritise hearing from the experiences of our colleagues in the system who are on this webinar. So we'll only focus on one or two areas in this quadrant here, highlighted in red ink. We're prioritising these areas because these are the most frequently occurring issues that we found working with systems. Although I just want to say that governance, leadership and system working are crucial underpinning enablers in each of these areas. Next slide, please. So let's start with understanding the population, understanding and planning for the population need, rather. Next slide. Understanding the population need is a starting point for planning for a mental health system offer with no gaps. Where there is a limited understanding of the trends in the need for mental health services and the gaps in services, decisions on investment are not well informed. And this manifests typically as gaps in prevention and early intervention services, and often presents the intended end-to-end commissioning across the spectrum of need. Where there is no analysis of the increased or changed mental health need, how can systems be assured of their capacity to deliver the level of interventions needed to match this? The result of all of this is the provider placed in a reactive position in responding to demand pressures as a result of insufficient capacity in the system. The result is long waits, prolonged suffering, people presenting with higher levels of acuity and in crisis. Furthermore, not understanding the population need also affects workforce planning in terms of understanding the capacity and skills to deliver the range of interventions needed. Now, while the LTP provides very clear objectives in certain programme areas, it does not constrain the Commissioner's role in planning to meet the unique needs of their population, as our colleague Linda will highlight in her piece, which comes next.
Hi, so my name is Linda Buckley. I'm a Mental Health Improvement Senior Manager for NHS England within the Mental Health Intensive Support Team. I've been working with NHS England for 2.5 years now, but prior to this I was a Senior Commissioning Manager working across adult, children's and perinatal mental health. So I was based in the South West region in Gloucestershire, which has a real mix of rural and urban localities. So lots of different challenges and lots of different pockets of deprivation that we need to take into account when we're commissioning services. So as a senior commissioning manager, part of my role was developing local transformation plans, obviously aligning to national policies such as the long-term plan, 5-year forward view, future in mind, better births, but also informed by our local demography and our local needs. So we had an up-to-date joint strategic needs assessment, and we also use local data and dashboards to reveal sort of local commissioning gaps and what the local need was. As you'll all be aware, sometimes your local needs and your local service transformation requirements don't always match exactly with what's available from national funding. So sometimes you need to develop your own local business cases and local service specifications. So I'm going to tell you about two of those that we did today. So we knew in Gloucestershire that we had an issue with our personality disorder services. We had a high number of individuals presenting to a number of our services with personality disorder. So they were coming to A&E, they were going to our GPs, they were going to Mental Health Trust, and because we didn't have anything local for them, we were sending them out of county, very expensive out of county placements, which doesn't always result in the best outcome for that individual either. So together with the local mental health trust, has developed a service specification for an in-county specialist personality disorder service, to try and keep people closer to home and to improve their experiences, and of course reduce the amount of costs and reduce the amount of money we're spending on out-of-area placements, but ultimately to improve the quality of care that these individuals were receiving. We also knew that we needed to improve our perinatal mental health services. So in partnership with both the Mental Health Trust and our local acute trust, we developed a service specification for a perinatal clinic that would cater for both mental and physical health needs for both the person that had given birth and also their partner. And this is before any national funding was available. So we took both these business cases to our governing body and outlined the business case and the benefits. But ultimately, due to funding pressures, neither of those services were funded at the time. However, a few weeks later, we received a request from NHS England, a call for bids for some small pot of funding that become available for the perinatal clinic. Luckily, because we'd had a service specification on file, we were able to use this one to respond to this request. And as you know, sometimes the timelines can be a bit tight. So luckily we had this one on file and we were able to submit it, and ultimately were successful in getting some funding. And the clinic was commissioned with a small few tweaks just to meet the specifications of the bid. So on all this, we were very lucky in Gloucestershire. We had a relatively well-resourced commissioning team in relation to some of our colleagues in the southwest and of course elsewhere in the country. So we had more capacity to develop these kind of prospective business cases and service specs. We also had a really strong ethos of partnership working across mental health for both adults and children, young people, and perinatal. And this was due, we had some very strong lead commissioners who really put partnership working at the heart of everything that we did, which definitely made life easier. So in terms of lessons learned, if you're able to develop prospective service specifications, even if they don't necessarily get funded at the time, it's always worth keeping them on file, because you never know when a call for funding may come.
With thanks to Linda for her piece. So next slide, please. So we'll now hear from Annie Murray from the Office for Health Improvement and Disparities, who will expand more on the role of JSNAs in understanding local population need and how this can be used to support decision making for commissioners.
Hi, I'm Annie Murray. I work for the Office for Health Improvement and Disparities. I'm going to do a short presentation on joint strategic needs assessments. Apologies I can't be there in person, but if you've got any question, please just put them in the chat and I'll try and answer them by giving written responses. Before specifically talking about joint strategic needs assessments, I just want to make the point that JSNAs are only part of the picture in terms of understanding local needs. Other sources of data that are equally as important are service data, and that's not just mental health service data, but also other relevant physical health and public health service data, for example, stop smoking, weight management and substance misuse services. Joint strategic asset assessments. So understanding both needs and assets will help identify gaps in current intervention services or programmes, and more importantly, reduce the likelihood of duplication in future commission arrangements. And last but not least, community voices. This includes voices of all communities that are representative for local populations, not just those who are currently accessing mental health services, but others who might be of greater risk of having poor mental health. So what is a joint strategic needs assessment? It's a tool for systems to understand and agree the needs of all local populations and communities. Local authorities have an obligation to produce them. Integrated care partnerships have an obligation to take account of them in their plans. JSNAs are based on a local authority footprint, and obviously integrated care partnerships can cover more than one local authority. So for your area, you might have to understand more than one JSNA. The Office for Health Improvement Disparities produces a range of fingertips profiles. In the mental health profile, it includes data for mental health and wellbeing JSNA. To get your local data using this browser, you must register, but it's easy to do. Data are organised across 6 topics: prevalence and incidence, risk factors, protective factors, wellbeing, which is new, services, quality and outcomes. Different indicators are available on different footprints, for example, local authorities, old CCG footprints, general practice and wards. However, not all indicators are available on all footprints. For example, income deprivation is only available on the ward footprint, while rates per 100,000 patients in GP practices in contact with mental health services is only available on a GP footprint. Mental health and wellbeing JSNA provides data, but it doesn't do the analysis. You've still got to do that yourself, or think about that yourselves, as this will need to include the other 3 elements as described in the previous slide. So, whilst each local authority has to have a JSNA, there isn't a set format. If you want to check how your local authority does theirs, you'll need to find it on their website and search JSNA. Some local authorities will have deep dives or dedicated chapters in the main JSNA or separate mini JSNAs for mental health and wellbeing. Some might have very little on mental health. If what there is old or it's not very useful for you, most local authorities have a process for adding sections and updating what they already have. If you'd like to update or add anything or do a deep dive for mental health, I suggest contacting your local authority public mental health team to find out how. JSNA reports can be quite long, and I've read ones that are over 100 pages long. It's a lot of information to take in, and it can be difficult to link the recommendations to the data in the report, particularly if the recommendation at the end of the report and the data is at the front. I really like Cheshire West and Chester's mental health JSNA. I like it because it gives you topic-based information, including data, some analysis and recommendations, and it's all on one PowerPoint slide, so it's really easy to see the connections between the data and the kind of ideas that you have to address some of the presenting needs. This is my final slide, and I've just put some links in here for you to kind of have a look at when you've got time. It's just to give you a sense of how different some of the JSNAs are. Thanks for listening. Thank you. Bye-bye.
With thanks to Annie. So I just want to, in the next slide rather, draw your attention on a resource that's been flagged by Annie, which is a series of 90-minute masterclasses that will support you to build and adopt a population health management approach in your day-to-day work. And these masterclasses are running in a number of regions. And I'm told they're accessible in East of England, Midlands, London, Southeast and Northwest regions. So don't worry, this flyer will be sent in the pack to you after this webinar. Next slide, please. So understanding the mental health trends in your population still does not tell you who will present to services for help. For instance, there are people who will recover without the need for interventions from services. And on the other hand, there are some who may require multiple services due to the severity and complexity of their need. So the key question is, what are the actual implications on services of this increased or changed demand? How does each population subgroup interact with the system, and what pressures is this creating elsewhere? Are we using cross-sector data to understand the impact on other services, such as police, for example? What are we seeing in service utilization data, for example, in terms of presentations to A&E? What intervention and support services are needed for each subgroup to prevent them from moving up the categories of risk over time, in terms of acuity, admissions, crisis, etc.? Have the wider community assets in the voluntary sector been identified and involved in devising strategies to reach certain population groups? And a very key question is, to what extent is each service able to meet any additional need in terms of clinical skill to deliver specific interventions? And has this been confirmed in demand and capacity modelling? So you need robust data and information systems to support this work, to draw out the intelligence and to help with ongoing monitoring of trends, usage of services and spend, as well as to ascertain the effectiveness of any actions taken in response. So next we have the provider perspective in sort of modelling this demand, and we have Colin Anderson from the Midlands Partnership NHS Foundation Trust, who will demonstrate how they modelled the impact of increased demand in their service. Over to you, Colin.
Thank you, Frances. Yes, good morning, everybody. Yes, my name is Colin Anderson. I'm an Associate Director at the Midlands Partnership NHS Foundation Trust. We provide physical health, mental health, learning disability services across primarily Staffordshire and Stoke-on-Trent, also across Shropshire, Telford and Wrekin. As an organisation, we've embedded a population health management approach across the organisation to help us to understand the current, but also to help us to predict future health and care needs. So what I'd like to do is to share with you a practical example of how we are translating demand growth estimates into demand implications for our services through the development of three-dimensional service profiles. And I'll finish with an example of what that is. Next slide, please. Thank you. So I think really to inform this work, we have used a lot of the resources that are available to us that have already been mentioned through local authority GSNAs, through NHS Digital, through Fingertips, and provided each of our services with a fairly comprehensive resource pack giving them population health information. So, for example, we provided our services with population projections over the next 10 years based on age, sex, ethnicity, areas of deprivation, and pulling out where, for example, we're seeing the biggest percentage change and challenges. Next slide, please. We've also provided for our services high-level patient profiles. So this is based on using existing activity information for our services, specifically attended contacts, and then combining that with the population projections, we're able then to provide our services with some forecasts for what that demand increase is likely to look like over the next 5 to 10 years. So this is an example of one of our adult community mental health services in Shropshire, Telford and Wrekin. So based on our forecasts and predictions, we're anticipating there could be up to a 6% increase in demand for that service over the next 10 years. Next slide, please. Just to support that, we've also done some forecasts around condition prevalences. So again, we've identified specific relevant conditions to each service, and through some linear regression modelling, we've added some forecasts onto those condition prevalence just to create a bit more of a rounded picture in terms of what that demand is going to look like, but factoring in specifically around those condition prevalences. Next slide, please. Additionally, we've also provided our services with information around those wider determinants. So, for example, income and employment status. So again, this is about helping our services to think about more of a holistic picture of the service user and the patient, and not just around the kind of clinical health needs, but getting much more of a wider understanding and taking into account what those wider determinants are. Next slide, please. So I think it's the million-dollar question is the so what, what does this mean for our services? What are the implications? What is the impact? So taking that information a step further, we've created we're calling them three-dimensional service profiles. We've created these for our priority service areas against each of our care groups. So each of those profiles then sets out the current financial, workforce and performance position, including some benchmarking data. So that's answering that question, where are we now? By applying the forward-looking PHM data, to help inform the future demands, and capacity planning helps us then to answer that next question about where do we want to be, and then being able to use that data stroke information to help inform what changes, what interventions, what transformation, what investment, for example, might be needed in the future to develop those services. Next slide, please. So this is an example of a service profile. This is really just setting out the principles of what we've done. So we've applied this across our physical health services and priority mental health services across our organisation. So the profile set out right at the beginning a service overview and an activity heat map around the local catchment of that specific service. The next section then sets out some high-level recommendations based on the demand. We've then split the service profile into 4 quadrants. So using the demographic information, we've pulled out some of the key headlines. So for example, population projected growth and ethnicity breakdown. The next quadrant then sets out the service user activity, so a breakdown of activity and demand for the service. The next quadrant then sets out the condition prevalence headlines. So again, for example, the percentage of people with health conditions that may impact demand. And then the wider determinant section sets out a comparison against the national picture. So that's on the left-hand side. The reverse of that then sets out the past and present. So this then sets out a financial overview of the service. How is it performing financially? Is it running at a surplus? Is it running at a deficit? We then set out the current performance picture of the service. For example, that may include contacts face-to-face versus non-face-to-face contacts and an activity breakdown. We then also set out the workforce position, for example, vacancy rate, staff in post, benchmarked where necessary, and then conclude with some wider benchmarking against national benchmarks. So, for example, contacts per 100,000 population. So it was almost like if you could imagine a double-sided A4 product sheet, forward-looking PHM data on one side, current performance information on the other side. So the so what, and my final point really is that for our services, this enables them to think more proactively about how to meet that demand in the future, whilst also delivering efficiency, improving quality, and addressing health inequality. But it's not just about more staff, which is a lot about what our services are wanting. Really, this is about educating our service and our staff to think differently and to do that right at the beginning of the process. And this enables them to do that. So, for example, what digital solutions could be potentially put in place that might support this work or support that service going forwards? And then I think finally, from a commissioner's perspective, really this approach from our perspective helps to provide more confidence and assurance from a planning perspective, specifically regarding any new cases for change for investment into new services would probably be a good example of that. Thank you. That's the end of my presentation.
Thanks very much, Colin. So we're on to another Menti now. So hold on to your hats. The next one is your main challenges in understanding and planning for your population. So before we were interested in your more general barriers, now we're talking about your understanding the nature of your population and the demography and planning for the future. Another word cloud, another minute. Keep them going. Data. Right, there we go. End of Menti. Really is just data. Goodness me. And, right, capacity. Thank you. Is it public health capacity to give you data? Okay. So it definitely feels like there's a real gap and a real challenge in terms of access to data, ability to use the data, and to put that to good use. So it's really interesting from our point of view in terms of understanding your challenges, and also, as we talked about earlier, in terms of thinking about what we might want to focus on for any future round of webinars. It feels very clearly that having the time and the skills and the access to data in terms of your population is absolutely crucial. Okay, thanks everybody.
Thank you, and thank you, Michael. Definitely keep it coming, and definitely please do get involved in some questions in the chat. You're very quiet, so please sort of don't just rely on the Menti, just keep it coming in the chat. So we'll get into sort of things to consider in this section when thinking about aligning the investment with the patterns seen in population need. We'll also sort of highlight some of the data sources available to support commissioners in making informed decisions on priorities for action. Next slide. So certain population groups, as we know, have vastly different experiences compared to others of the wider determinants of health, such as social, economic, and environmental factors. And this drives the risk of mental illness. Health inequalities are defined as the systematic, avoidable, and unjust differences in health and well-being between different groups of people. We have evidence now that racism has a detrimental impact on its own on overall health and mental health. Exposure to racism has been estimated to increase the likelihood of experiencing mental health problems such as psychosis and depression. Often marginalized groups tend to be unaware of or presented with alternatives when the initial intervention has not worked. It is crucial to build services around these groups in such a way that the mental health system does not itself inadvertently perpetuate the structural discrimination these groups face. This means providing targeted support to such groups. In a few minutes, we'll talk about the types of data sources that will help you to understand any differences in access and outcomes between groups. I want to draw your attention to the recorded resource that will be available next week on our Futures page from South West London Ethnicity in Mental Health Improvement Programme. And this gives a really powerful insight as to the things to think about if you want to achieve meaningful involvement and participation of service users and community groups to shape services towards achieving health equity. Meaningful involvement, that is, as opposed to tokenistic approach. There is also a comprehensive how-to guide to commissioning for equity that has been produced by the Royal College of Psychiatrists, and this is the Advancing Mental Health Equality Guide. Linked to this is the Patient and Carers Race Equalities Framework to help organisations work directly and effectively with ethnically diverse groups to ensure that their feedback drives changes within services. This is currently being piloted in 4 areas nationally. In a previous webinar, we highlighted the HEAT tool to identify targeted interventions to reach currently excluded groups and to plan how you will measure their impact. In summary, taking action on health inequalities requires improving the lives of those with worst health outcomes at an accelerated rate. I shall now hand over to Nick. Next slide.
Good morning, my name is Nick Gitcham. I'm a member of the Mental Health Intensive Support Team, which I joined 6 years ago after working in a variety of improvement and transformation roles in the acute sector. So Annie and Colin have spoken very clearly about some of the different data sources we can look to get a really detailed understanding of need. I want to go back a step really and think about how systems make decisions about how much of their funding allocation they're allocating to physical healthcare and how much they're allocating to mental health care. So as you know, the Mental Health Investment Standard, the MIS, was introduced 7 years ago now in recognition of the fact that there's been long-standing historical underinvestment in mental health services. And it's been an extremely effective mechanism to ensure that the levels of spend on mental health have increased across the country year on year. But importantly, it's not a panacea, and it actually doesn't relate to the meeting the MIS doesn't relate to meeting the level of need for mental health services in a local area. To understand that, we need to look to the Mental Health Needs Index, which has been developed over a number of years using multiple data sources and taking into account all the different demographic factors which influence the level of need for mental health care within an area. And what we see is that there's actually no correlation between the Mental Health Needs Index, which determines how much funding allocation areas get each year, but there's no correlation between the needs index and the actual level of spend on mental health care in different areas. And many of the areas that were spending the least on mental health care in terms of need in 2015-16 continue to spend the least, despite having met the MIS year on year since then. And we also see that actually the areas with the highest need tend to spend least on mental health care per weighted head of need, and the areas with lower need. And this is particularly evident in the larger cities, London, Birmingham and Manchester notably, but not exclusively. And this clearly is leading to health inequities, which are predominantly linked to ethnicity, to age and to deprivation. So the takeaway really is that systems need to make conscious and deliberate decisions which are informed by the data on need when determining how much of their funding allocation they're spending on mental health care as opposed to physical health care, rather than simply taking the investment level last year and inflating it by whatever increase you need to meet the MIS. So next slide, please. So here's an analysis, and this is using 21-22 data, so at CCG level, but it's highlighting all the CCGs which are now in one of the larger ICBs, and the colour coding represents the funding to two of the main providers within that ICB. And we can see that across the country, the average spend per head of need on mental health is just over about £210. But in this particular ICB, only in one area are they spending average, and in most of the other areas of the ICB, they're spending significantly less. And we can see that across the country, there's a threefold variation in the levels of spend per head of need. So this also highlights that despite having obviously moved now to ICBs, and that's the indices that will be used going forwards, it's going to be useful for ICBs to still refer to the CCG level data to understand that the fact that within any ICB there will be variation in the level of need. Okay, so on to Menti now. Can you let us know what information sources do you find most helpful when you do make your commissioning decisions, either types of information or specific sources? So if you can share those with us, we'll see what comes up. I don't know if this links, the lack of any responses so far links to the last Menti in terms of the difficulties in either accessing or obtaining the data, but now it's coming in. So core data pack, internal trust data, NHS England data, JSNA, fingertips, benchmarking, yep, all good and useful sources. Nothing particularly dominating now. Fingertips and JSNA are coming out slightly higher. Care plans, service users, that's great to see that. Patient voices, that's something we haven't particularly covered, but obviously a really important element, not just the data in terms of populations. Great, thank you. So I'll pass on to my colleague, Sean.
Hi everyone, my name's Sean Griffiths, Mental Health Improvement Senior Manager within the team. I worked in mental health nursing and operational roles prior to coming to the team around 2 years ago. And I'm just going to talk briefly about some of the metrics and a bit about data. We can see from Word Clouds people spoke about data and accessing data, so hopefully go through some and people have a few more ideas where we can look First, I'm just going to talk about some of the metrics that are key to understanding some of the issues within services. This has been broken down into two sections, one around access and the other around flow. Firstly, when talking about access, these are some metrics, and so all these metrics can be, all but a couple can be accessed through the model mental health system. But if we're looking at access, when we have high use of section 136, high use of section 2, high presentations at A&E, admissions through A&E, this indicates that people are accessing services through crisis methods. So that we may need to look at where we invest and where we commission services differently, so that people are accessing them not through crisis and accessing them through GPs and routes that aren't through crisis. Next slide, please. Next, we've got the metrics that we have around flow. So these are metrics that indicate if there's an issue within the flow within the system. And we can see here we've got high rates of discharge at assessment, large caseloads with low turnover, long inpatient lengths of stay, and particularly inpatient lengths of stay that are over 60 days, long wait for services, high DNA rates and no contact rates. And we can see the last one, this is more local data, but multiple assessments. And this is something that is important as well, because if we've got people that are presenting at multiple assessment services, then the flow through the service isn't what we need it to be. So people aren't progressing through the service, and they just keep on going to assessments and then having similar assessments again and again. And next slide, please. And next, we're just going to go on to a few of data sources, and this is looking around health inequalities as well. So these are data sources we can look at to establish not only what we're talking about around access and flow, but we can see if we are representing the demographics of the service users that our services are targeted towards, and also that people are accessing at the same rate. So this metric is included in the core data pack, and this is around inpatient admissions that have had no previous contact. So this can be broken down so you can see ethnic minorities and if they're accessing service. If you've got a high percentage or a higher percentage than what your demographic is serving, it could indicate that people ethnic minorities are not accessing services through usual routes and are going through crisis or not having any previous contact and then go straight into inpatient services. So we may need to look at how we are outreaching to different communities. Next slide, please. Next, we've got, this is on the mental health bulletin and dashboard. We can see here that these metrics around ethnicity that are within secondary services, so they're broken down into different ethnicities, and we can see if this is a representation of our population. So if we've got high levels or lower levels within different ethnic minorities or different patient groups, then we can see that we don't have the representation. So we need to think about how we can reach out to different demographics. Next slide, please. And finally, on the data sources we're going to focus on, we've got the model health system. Now, there is multiple metrics on here and compartments where we can look at ethnicity, age bracket, and gender breakdown. There's just a table so we can see where the different metrics sit and how you can break those down, so we can look at who's accessing services. So if we've got a misrepresentation in certain age brackets or different ethnic backgrounds that are not accessing services or are misrepresented in services. And also it gives us the ability to see if there's certain patient groups that we may want to think differently about how we engage with them. And there's instances around the country where different providers have reached out to specific patient groups because they're underrepresented within their services. So they've reached out to, for example, Asian populations, traveller communities, and engage with them to see why isn't that they engage, why don't they engage, is it there an understanding, and try and break down some of the stereotypes, and so that we can have a better service for all the patient groups that we serve. Next slide, please. Finally, here is a table. Now, this is all of the different sources that we have. There's a lot of different dashboards. So when we get the slide pack, you can look through in a bit more detail and see the different dashboards and how they can benefit. So we can see on here that we've got, like, for example, mental health policy dashboards that help with benefits for planning and commissioning, benefits for quality improvements, benefit for equality. So we can see if you're looking for a specific area, if we're trying to say we're looking at how we look at equality better, then we can see the different dashboards that we'll be able to access to hopefully help us have a better understanding of how we're representing ethnic minorities or age groups or different areas. I think now I'm handing over to Francis.
Thank you very much, Sean. Okay, so we've had a bit of a sort of a focus on health inequalities there, and notwithstanding the feedback that you confirmed in terms of the constraints in workforce and funding, definitely I think you will agree that there are things that we can do to ensure that those accessing our services achieve equally good outcomes, and all communities are able to access the services that you've commissioned. So once you've identified your local priorities for investment using these data sources, speaking to service users, representative community groups, etc., there's the small matter of persuading typically your ICB to commit additional investment beyond the MIS, given other competing priorities, typically in the acute sector. I won't go through the details of all these in this slide, but it shows you what you already know, which is that there is a strong business case for mental health in terms of economic and social benefit, as well as substantial benefits to the system in non-mental health NHS spend. But talking to commissioners, many have shared with us that they do not often feel that in reality they have as much influence as they'd like on the decisions on the size of investment that actually gets passed over from their organisations for mental health delivery, let alone securing investment outside of programme areas covered by the MIS. This may not be your reality. And if it isn't, please do tell us the secrets of your success. So we've got the next Menti cloud to enable you to do so.
Thanks, Francis. So yeah, so for those of you who were successful in getting your ICB to give you additional investment, putting aside any finance chaos they might be encountering, what were the key things? What were the key arguments or bits of leverage that you were able to use in order to increase investment in mental health services? 1 minute, as per. If we don't get any responses, we'll assume that nobody managed to get any extra money for mental health, and it'll be a very depressing story. But we'll at least support some of the conclusions from Nick's slides. Relationships. Oh, evidence. So someone somewhere has got some data and has used it to evidence the need for increased investment in mental health services. Please do get in touch if you've got a success story there, because we'd love to hear it, presenting accurate data. Absolutely. I think it is telling that one of the greatest barriers that people described earlier was not having easy access or ready access to the data that they need, and that where extra investment has been secured, it has been data driven. It really feels like there's an opportunity there for improvement.
Absolutely.
Brilliant. Thank you very much.
Thanks, Michael. Okay, next slide, please, Louise. So we'll now sort of highlight some issues that we came across relating to investment. Next slide again, Louise. Great stuff. Okay, so one of the frequent requests from systems that we worked with was they asked us to help them get an understanding of the implications of their current investment on the service's ability to deliver and sustain national targets in the LTP programme areas that we were commissioned to support. And this is because there was often not shared understanding or sometimes even very sharp differences between the commissioner and provider on the levels of investment into services. This often hampered progressive conversations and turned out to be the elephant in the room. So even in the highly scrutinised national programme areas, we found a tangled web of issues, such as the full extent of national allocation not being identified in commissioner baselines, inaccuracies in commissioner investment and provider data, investments not aligned to contracts, no specific agreement on the activity levels associated with that investment, no reconciliation processes to confirm the extent to which the investment had translated into service line budgets, no processes to assure investment levels were sufficient, as I said earlier, to secure the coverage of the population, achieve equity and high quality service. As a result, there was often mistrust between commissioners and providers when, for instance, commissioners felt they were paying differently for the same service compared to neighbouring commissioners who were also reliant on the same provider for delivery. So the reality of these unassured investment levels will be, seeing differences, for example, in the spend per head of prevalence. And these are the sorts of we use very high level sort of comparisons to start the conversation and explore some of these differences and sort of get the conversation going. We'll now hear from Elaine Buckley on how she set up transparent governance processes in contract management. Over to you, Elaine.
Thanks, Frances. My name's Elaine Buckley and I currently work in the ICB in Lancashire and South Cumbria, but I've been asked to speak today about my time as contracts manager with Lancashire and South Cumbria Foundation Trust across Lancashire and South Cumbria commissioners as they were at the time. So when I came into post, it was felt that there was a real level of disparity and confusion and a slight level of mistrust in regards to what people were investing and mapping that through to contracts. So, for example, we had variations to services and that covered additional finance or additional activity not being agreed and breaching timeframes. We had misunderstanding around expectations driven by the expectation of one kind of gold standard service, but there was differing investments. So what did we do? Well, the aim was to create a transparent, accountable governance structure, which had clear processes that all parties were signed up to. That's really key, all parties, so the provider and all the commissioners. So at that time, we had one main Lancashire and South Cumbria mental health contract with Lancashire and South Cumbria Foundation Trust. So we had a main host and 6 associates who were heavily invested in that contract. So what we needed to do was manage expectations and deliver for both sides. And we wanted that to support both providers and commissioners so we could work together to achieve the expected system and local performance. So what you're seeing on the slide there is the first step for that. How do we work together? Well, it was a team effort and we looked at the governance structure. We needed to make sure there was accountability. We needed to make sure there was a place for people to come together and manage accountability and expectations. So that team effort, from a commissioning perspective, was quality finance contracting commissioning. It wasn't just me, it was the team that brought it together. We wanted to make sure that all parties across the commissioning element were aware of unintended impact as well. So when you're in a position of mistrust, that drives more and more requests for activity, more and more requests for quality data, more and more requests as to where is my money, etc. So there was also an element with provider where, if you're going to make changes, we need to hear about that too. So it was both sides. So we wanted to open regular communication. So what you're seeing on the screen here is a very simplistic view where we thought that we wanted to have an operational group, which was a contract kind of service level, the middle level there, which would then go through up into an executive level. And it was for people to commit to this governance structure, commit to the requirements of the governance structure and attend. And what we drove through the contract kind of operational group, it was a quality one and an operational one, and we'd look at everything through there, which was to do with the processes, which I'll go on to in a moment. One of the key things here was the performance improvement subgroups. So all parties committed to, if there was an issue or a concern raised and it was seen as valid, we would stand up at times performance improvement subgroups, but they and a clear boundary as to an end. And the key was to build the trust with that end. So there's a temptation, if a group is working well, that we add more onto it and say, let's do this more, let's do this again. Well, these groups were, this is to solve this. The providers would heavily support that. They would attend, they'd give additional information, and then we would close it down. But if we closed that down and kept the remit within where it should be, it meant that we were more likely to continue to have them as and where needed. They were almost like spotlights. So what we were trying to manage through this governance group was proportionality. So proportionality in requests and refusals. So requests from the commissioners, refusals from the provider, and creating a gateway that would filter both ways, manage the size of the ask, make requests smart, but also empower commissioners with the knowledge that this is being asked for over here. Would you like that? Let's work together as a system so that if you're affecting change over here, let's see if that can be replicated across the system. So next slide, please. So we created an element of process management. This isn't news. A lot of this is contained within the contract, but it's not visible for people who are managing or working, such as commissioners and service managers, to say what happens if we need to follow this process. So we highlighted the main key processes, such as variation, and that would be financial or activity based, or things like data issues or activity information flow. This is all spelled out within the contracts, but we don't quite say how are we going to enact that, how are we going to use that. And the key to the success of the process management processes was that all parties signed up to it. They were refreshed annually as a minimum in line with guidance from contracts. And we also looked at some additional ones, which was around raising queries on contracts, which I've drawn attention to there, and the additional activity requests. This was because it could feel like at times that they would, the additional activity request was, let's make them smart, like let's make them less onerous, but let's make sure they follow a process. And that was really successful in making sure that if we ask for something, we need it. And if we need it quite urgently, so let's keep to time frames. The raising queries on contract allowed us to say we're concerned without putting a performance notice in. So these were really helpful tools and techniques for us as commissioners and providers to work together and ensure resolution through, so that we wouldn't have a variation that had been unsigned for 10 months. They were signed, and quite often. So that's a very quick whistle-stop tour. I can't tell you everything. It was a real team effort. Key to getting to this point that you're seeing on the screen of following the process management and the governance structure was to understand your services and investment. Make sure your service specs are updated. If they're not updated, acknowledge that they're out of date and that people cannot be held accountable. That they're mapped to finance lines. What are they? Is there some confusion there? Acknowledge it and bring it out in the open, and let's resolve it. Implement the governance structure, implement the agreed processes, discuss any concerns and make sure all parties are signed up. Try and ensure that the wider commissioning colleagues are working collaboratively to really understand unintended impact. In my experience, it's genuine unintended impact, and follow through and completion of requests. An issue should follow, and it builds trust and it builds in support to support the governance structure, support the processes, and also make sure that executives are linked in and supporting the whole infrastructure. But that's it from me. Thanks, Francis.
Thank you so much, Elaine, and I hope that was really helpful to hear. I certainly found it really refreshing. So some of the key themes of our recommendations on investment lie in the checklist that is on our futures page, so I'd direct you there. What we found in areas that achieved a good understanding among partners on the investment and where it should be prioritised, they had set this out, investment per partner, clearly and transparently in strategic documents. Another one of our frequent recommendations was that investment should be linked to the delivery for the entire pathway of evidence-based interventions, not just, for example, to first treatment. Because if investment is insufficient, it's not unusual to see undesirable responses to services against sort of demand pressures, such as narrowing the service scope, rather restricting or capping sessions in evidence-based interventions, which of course leads to poor recovery outcomes. Now, time's marching on, so I'd like to sort of gallop a little bit and go into sort of perhaps outlining some of the issues that we found in the service spec. So if you could move on another slide, Louise. So a clearly defined contract specification is a key lever for delivery, supported, of course, by the sorts of governance process that Elaine talked about. The service specifications that we came across in struggling systems had a few issues, and they were sort of ambiguous expectations in the service scope. For example, the range of services or interventions that the provider was expected to cover. They did not clearly set out the service model, and of course this got in the way of achieving a clear system offer where the most appropriate service can be identified to meet the individual's need. It also got in the way of workforce planning. We have some examples from early intervention psychosis services where some providers felt they had not been contracted to support those in at-risk mental health states. And this was obviously a clear opportunity lost in the benefit of a specialist EIP service to intervene early and prevent transition to psychosis. Another example, again from EIP, is where the contract left a degree of ambiguity as to who's responsible for delivering physical health assessments and interventions for this client group and how services could work together to deliver this. And this is a client group we know die on average 15 to 20 years earlier than the general population as a result of physical illnesses like cardiovascular diseases, respiratory and metabolic diseases. So often missing also in service specs were a set of defined outcome measures for service users. Local services were unaware of each other's offer. And we also found that struggling systems were not making use of commissioning models, to make sort of best use of financial resources. So for that, I mean sort of the lead provider models, the alliance agreements, and these are forms of contracting to support a coordinated approach to delivery. And they incentivize a number of providers to come together and cooperate across their boundaries to achieve the common objective of delivering certain patient outcomes. So the thing to do is obviously to address all of these areas. You'll get these slides, so I won't go through this slide. So next slide, please. Neither will I really go through the next slide, please, Louise, which is sort of the point about apportioning activity and making sure that each organisation knows exactly what it's responsible to deliver, because of course this has implication on staffing resources. So this is really about sort of making sure that the agreed activity to be delivered by each provider sums up to the total expected by your system at the level that performance is managed. But I do want to highlight some key underpinning processes, which is essentially provider owned, but is of particular interest to commissioners to assure that they are in place, and that's the sort of the area of accurate data flow. Data was a key theme in one of the mentees, and the opportunity of leveraging the data quality improvement plan where necessary to ensure that provider is capable of sort of flowing routine outcome measures and the collection and submission of outcome data, which would help in sort of determining the sort of overall benefit of your services. Next slide, please. Okay. So this is just showing you sort of, we are down to sort of like the last webinar in this series, and the purpose of the past 6 webinars in this series is to sort of equip provider colleagues with the tools and insights into good, sound operational processes, which is really essential for sort of minimizing delays, minimizing variation, so that all can achieve equally good outcomes. And this is an example of some of the things that can, we can implement now, notwithstanding the challenges in workforce and funding. There are some clear opportunities within services, although I have to stress workforce and funding are essential factors and constraints. Next slide. Okay, so now I want to say a few thoughts on outcome measures, and this is the last section of our webinar. And perhaps if I can sort of skip over this Menti, because I really do want you to have the benefit of hearing from other colleagues in the system. So in terms of barriers to delivering good outcomes, next slide, please, Louise. Thank you. So we found among systems we worked with that outcome measures were not consistently used or reported for service users in mental health. The exception of this, of course, being talking therapies, formerly IAT, where this is an integral part of the model. And the key reason that we found in struggling systems lay in the culture and understanding of the benefit of the use of routine outcome measures in both the commissioner and the provider. And in this situation, the quality and effectiveness of interventions delivered by the service cannot be effectively monitored. And as I said before, where there were KPIs that were narrowly focused on national performance targets, which hampered the visibility of in-pathway weights, for example, which are associated with clinical risks and pathway flow issues. And in fact, in-pathway weights has been highlighted by the CQC as a particular gap in corporate oversight in many mental health trusts. Next slide. It's important to look beyond the headline KPIs and agree collectively as a system what the service is trying to achieve, or what you're trying to achieve through the service, and the challenges that you are seeking to address. So at service level, there's often a vicious cycle operating in the interaction of a set of factors that contribute to the delivery of poor outcomes. So, for example, inadequate activities commissioned due to the service being perceived as being full due to long waits. This will have implications on the investment, consequences on capacity. With insufficient capacity comes poor service flow and throughput. Services may then respond to long waits by applying high referral thresholds to suppress demand, and we know that long waits suppress referrals by GPs or other partners due to the perception, again, of service being full. So in this scenario, just chasing the national performance headline numbers can give false assurance and may even worsen service user experience, and is certainly demoralizing to staff. So looking at additional contextual measures enable greater visibility of these issues and for you to track the impact of any improvement actions. Next slide, please, Louise. Okay, so as you can conclude, what works well is an expanded set of KPIs to include some contextual KPIs to monitor service performance, promote an understanding of how service is working, and the risks, and also to inform future planning. So this set of sort of KPIs should include some balancing measures to avoid the unintended consequences of hitting the target and missing the point. So, for example, achieving waiting time targets based on waits to first treatment, where you've got a growing number of patients experiencing in-pathway waits. And sort of continuing on the waiting times theme, it's important to understand the underlying trend in the growth of the waiting list size. As the waiting list grows, people wait longer, their clinical symptoms will deteriorate. And as the waiting list grows beyond the ideal waiting list size, you'll have backlogs building, waiting time breaches, etc. Thinking about recovery, it's understanding who does not recover, and whether the service is capping the number of intervention sessions, for example. What is the impact of DNAs and dropouts, which mean people exit the service without intervention? And it is important to consider the impact of any additional data that you're asking the provider to provide you with. There is a range of data sources out there to help you to understand your pathway. Finally, routine outcome measures needs to be considered alongside a broader set of measures that are meaningful to people, such as remaining in employment and education. There are a number of measurement scales out there to ascertain sort of, the changes in clinical symptoms, etc. But it's really important also, in addition to all of this, to capture the qualitative feedback from people to understand the impact the service is having on their desired goals. Next slide, please. Okay, so all I want to say, which this slide captures and you can sort of read at your leisure, is that additionally, it's important beyond sort of specifying these outcomes, it's important to have the mechanism in place to make sure that they are routinely reviewed to support service delivery. It certainly needs to be a high priority as a standing item on the ICB agenda. You might want to reflect whether that's the case and that there's a clear reporting structure within organisations from sort of, team level to board level. And importantly, that there are sort of like processes for an annual whole system review between commissioners, providers and service users to examine any gaps and issues in the system in order to improve the offer and certainly sort of make any amendments to contracts and specifications. Next slide, please. Okay, so thank you for listening and participation in today's webinar. Please stay on to listen to our colleague Lisa Nolan, who will bring together all that we've discussed in what she's about to share in a minute. Please definitely sort of visit our futures page for the checklist and tell us what's missing. Next slide, please. We did say that we'd want you to continue the conversation, and that red arrow shows you, or at least this slide shows you, the path to that conversation space. Please use it. I'm sure there's lots of great things out there, and there's certainly challenges out there, so please use it. Also, I want to flag that there's so much more that we wanted to tell you, and we've had some fantastic collaborators who couldn't be here today. We had Hayley Payne from NHS Gloucestershire, Lila Johansson from Berkshire West. We've also got Gemma Dawson from Southwest London ICB, and we've got, between all of these collaborators, they've put together additional videos on innovating with investment, meaningful involvement and participation, reflections on what it means to be a commissioner nowadays. So please, over the next week or so, do access this space. Can I now invite Lisa to share her experiences in commissioning an integrated offer for CYP?
Hey, morning everyone. I'm Lisa Nolan, and I'm going to finish off this webinar today. I currently work in Liverpool Place, which is part of Cheshire and Merseyside ACB. I've been a commissioner for 20 years, long time, and I'm going to outline the principles of the commissioning cycle that we use to develop a children and young people's mental health whole system integrated offer. Next slide, please. Okay, so the first step we took was assess a need to understand the why and the what, and some of these have been discussed today in the webinar. So why we needed to do something, and as you can see from our local profile, there are lots of reds, which would indicate a lot of risks associated with poor mental health. Our prevalence in Liverpool is also quite high based on these risks, which equates locally to 18,500 0 to 18-year-olds and 16,500 17 to 25-year-olds requiring mental health support. And the what, so what we needed to do, and many of these are outlined on the slide. Just to say, it's really important to work with your business intelligence, public health and contracting colleagues and wider stakeholders, including children, young people and families, to understand need, as they will support you with a number of areas identified, many of which have been discussed today, including gathering the intelligence, undertaking JSNAs, demand and capacity modelling, and more importantly, the voice of the population. And that will really help get a clear understanding of the local landscape. Also to note is the importance of acknowledging the fact that CYP mental health crosses a number of areas. Crosses CYP agenda, SEND, transforming care, physical health, maternity, and therefore the whole system commitment and ownership is vital to moving forward. Next slide, please. So then we used what we knew including some wider enablers to look at how we wanted to develop our vision and plans using an outcome-based approach with clear underlying principles, which again are outlined on the slide that you can see there. And given this is a whole system collaborative approach to a CYP mental health offer, it involved multiple organisations, disciplines and personalities. And therefore, as you can imagine, it hasn't been an easy task. And at times there was and still is conflict and differences. So some of the enablers on the slide are really key in working together, such as building healthy relationships, strong leadership, and always revisiting the purpose and the vision. It's also how you manage this conflict and ensure there's a safe space to have honest and open discussions, which generates respect and a learning environment as well. Next slide, please, Louise. And so this is the delivery stage, and this is our local offer. It outlines our whole system offer from prevention and self-care to early help to more targeted and specialist provision, with some additional targeted support to meet the needs of our most vulnerable populations. It's for children and young people aged 0 to 25 years and their families, and it's delivered by our Liverpool CAMHS partnership, which is a collaborative of NHS and third sector organisations across health, education and social care. And this has been in place for a number of years and takes a needs-led approach, as you can see along the bottom of the screen. This is actually a high-level visual, and I haven't actually got time to go into detail, but please feel free to contact me about it. But hopefully you can get an idea of what has been delivered. But for the purposes of this workshop and the commissioning cycle, it's just important to outline that the providers within the Liverpool CAMHS partnership all have a specific part to play in this offer. And they're all signed up to the citywide vision, underpinning principles and meeting the agreed outcomes. They all have separate NHS contracts with clear specifications outlining their requirements. And to strengthen this collaborative approach, there is an MOU, a Memorandum of Understanding, built into contracts that providers have signed, which requires them to work together on some key areas such as resource, estates, workforce, pathways, training, promotion and intelligence. And they meet together regularly to discuss this, including having weekly MDTs to discuss complex cases for that step up and step down approach. We in Liverpool didn't go down the lead provider model, but we have explored alliance contracting, which we might take forward in the future. And more information about this offer can be found on our website, and I put the link on the first slide, and that gives you access to our digital front door with a wealth of information. Next slide, please, Louise. I've got a minute left. So how do we know this offer is working? Again, Francis just talked about the importance of review and monitoring. Well, ours has been continually reviewed, and I've outlined how this happens on the slide through strategic and provider level oversight. The strategic level oversight is undertaken through the quarterly place-based CYP Mental Health Strategic Partnership Board, and this is multi-agency and includes representation of parent carers and CYP Voice. It provides a clear governance and accountability framework at place for progress against the work plan, outcomes, demand and capacity, quality and national targets. It provides that support and challenge function. It is also a forum to outline any risks and plans to mitigate against these. A system maturity tool is also undertaken annually when the plan is also reviewed and refreshed. And at provider level, there are quarterly or monthly contract meetings in place with all contracted providers, and this allows for assurance against what is being commissioned through contracts and specifications, but also allows for that two-way discussion and building of good positive relationships. It allows us to understand any operational challenges, but also the story behind the numbers reported. Quarterly, monthly returns that are completed focus on activity, quality, outcomes, workforce and social value. And if we've also received some really great social value and social return on investment reports. An example of this is that one of our providers has evidenced recently a social return on investment of £68,000 per family, which is really good for business cases. And all our providers also report into the National Mental Health Service data set, which we invested in. There's been many challenges. I've excluded data on here, which came up before, and data is always a challenge. I've spoke about some of the challenges in earlier slides around conflict and differences through work and cross-sector. Many of the challenges you mentioned before on the Menti Cloud. Resource and funding is a huge challenge, and that includes funding and workforce. there's not a level playing field between the NHS and third sector organisations, and we've tried to manage that by giving all our NHS third sector providers core NHS contracts. I would say also it's really important to be friends with your finance colleagues. Also, the restructure. So the NHS have recently restructured from CCGs to ICBs, and this has also had an impact specifically on the role of commissioning. This challenge is probably different across the country as the ICBs are in different stages of development. So I would say to the commissioners out there, keep going and hang in there. And also can't emphasise the last point is time. There is continual pressure on the system currently in order to develop and transform and undertake the cycle of improvement. So people do need time. It needs to be built into job plans, especially at practitioner level, which is much needed aspect of understanding needs and evidence base, in addition to the important time given by children, young people and families, which needs to be acknowledged in the appropriate ways. And that's me. Apologies for going over time, but thank you for listening.
Thank you, Lisa. We are over time. We were going to have some time for question and answers, but actually we don't seem to have had any questions to discuss. But please do use the Futures platform in the chat that Francis has made reference to carrying any conversations. And very importantly, we are an improvement team and like to use evaluation in terms of seeing how we can further improve our products and our webinars. So please do use a QR code that is here to give us some feedback. Thank you. Next slide, please. So yes, I think we've Francis touched on this actually, that we do have a Futures webinar. We are able to provide systems with free bespoke coaching, support and consultation. So please do get in touch with us. And I think the next slide provides our contact details. There you go. So you can see there, each of us has a link to each of the regions, but please feel free to get in touch with any of us. And once again, apologies for keeping you ever so slightly over time. And final plea to click on the QR code for the evaluation for commissioning to Optimise delivery. And just a massive thanks to all the presenters today and the participants within the call. Any final words, Francis?
Oops, mute there. Thank you all. Hope this has been helpful. And by all means, if you have any ideas as to which areas that perhaps we look at in more depth, maybe in collaboration with other teams, please do put that in the evaluation form. That's really important. Tell us what you thought about today. Tell us what you want to hear more about in the future. Tell us and tell your stories in the platform that we've made available to you. But once again, thank you for your time.